Hello. Yeah, I think this one is on.
Let me shut that one off. Can you, because that was incredibly annoying listening to that microphone. So, Mark Reswell, thanks for having me out here. Can you guys all hear real well with this mic along?
Yes.
Good. So, I'm with Illinois Bone and Joint Institute. I work in Morton Grove, Des Plaines, and also Highland Park. I did an arthroscopy fellowship in the sports medicine. I do a lot of shoulder and knee work, and today I'm going to be talking about just general shoulder problems in the orthopedic world that I see in my office. A lot of them translate to IMEs, work comp related issues, and obviously a lot of patients just right off the street come in with these problems. They're very, very common. The shoulder is very commonly injured primarily because it is one of the largest ranges of motion of all the joints in the body. And that's a great thing because we get our arms and hands lots of places we need them to go, much more than our feet. Luckily we don't grab things with our toes too often. But the reality is that extra motion, while being beneficial, also puts that shoulder at risk for a lot more injury than the hip, for example. There's not as much hip problems that I see. Dr. Dome's going to talk about it. Maybe present a very different opinion of that. But the long and short is we see a lot more shoulder problems come in the office than hip in general. And that's because most things we do in life involve our shoulder, whether it's sports, whether it's work, and everyday activities. Just activities of daily living, brushing your hair, putting on your clothes, are things that put your shoulder at use and exacerbate symptoms or make things hurt where they weren't bothering you before. These can also be traumatic injuries or overuse injuries as well. If you're doing a lot of repetitive overactivities, you can develop some shoulder pain, or falling down or getting struck in the shoulder can also cause these symptoms to come about. So recognize that depending on how old your doctor is that you're working with, what part of the country that they're trained in may impact how they look at this and how they feel about things. Whether or not they keep up on the latest greatest literature also may impact how they manage these different types of pathologies. So the important thing is to communicate with the physicians you're working with, get a better idea of what they're doing, why, and what the expectation is in terms of the results of that treatment. I'd like to start a little bit with the anatomy. It's the building blocks of all the musculoskeletal system. In the shoulder, the bones that we're dealing with are the humerus bone, which is the top, the humerus is the ball of the shoulder. The socket is part of our shoulder blade. So the shoulder blade sits on the back of your chest wall, and the socket is the most lateral aspect of that. Also above is the clavicle. A lot of shoulder injuries involve that clavicle. It's a very superficial structure underneath the skin, and it's very easily injured. And then the shoulder blade itself is a structure that is not very often involved in pathology, but dysfunction of that shoulder can throw off the mechanics and cause symptoms related to that joint. And we throw out the most famous muscles of the shoulder. These are the ones we work out in the gym, the ones that make us feel macho, our pecs, our deltoids, our lats. These are the ones that are most visible to the naked eye, but the ones that are less commonly involved in aches and pains that we experience. And rotator cuff problems I see every day in my office all day long. The number of pectoralis major tendon tears I've seen in my career is maybe 15, 20. So they're just a lot less commonly injured, these more superficial structures. Ligaments are soft tissue structures that connect the bones together, versus tendons connect muscles to bones. And a lot of people don't know the difference, but this is exactly what the difference is. The rotator cuff are actually the muscles that surround that shoulder blade. So around that shoulder blade are four muscles. Those muscles send their tendons to wrap on the bone. And again, the tendons connect muscles to bone. These four tendons form a cuff around the bone socket joint, so they're called your rotator cuff. A lot of patients come in and wonder about the rotator cuff. It's actually a cuff that we're talking about. They're also described in relation to that shoulder blade. So you can see there's the spine of the scapula is that bone that's poking out on the backside there between the muscles. So the supraspinatus is above the suprascapula. That's the one that's most commonly injured with most rotator cuff problems. Infraspinatus is below that spine of the scapula. Subscapularis is below or in front of that scapula. So they're named based on the relationship to that the bony anatomy itself. Then there's a lot of other supporting soft tissues that become important in our conversation. There's something called cartilage. There's two different types of cartilage in the shoulder. The first covers the ball and socket joints. So if you think about a chicken bone, that gristle on the end of a chicken bone, that's cartilage. That covers the surface of the ball and that surface of the socket. That's what's worn away when someone has arthritis. Versus the labrum, this is basically a ring of cartilage or a washer that surrounds that socket. I describe the shoulder to my patients like a golf ball sitting on a tee. And so when you injure the labrum, you're basically knocking that lip off your golf tee. And the plateau of that tee is typically the glenoid or the socket. And that's what's covering that surface cartilage. So these are both anatomic specimens and cartoons of these different structures. The other important piece of the puzzle is the biceps. The biceps is most famous for being in the front of that arm when you flex your arm. But one of the parts of the biceps, the tendon, that again connects the muscle to the bone, goes into the shoulder joint and attaches to that top of that ring of cartilage, the labrum. And there's injuries that occur in that location specifically that we'll talk about. And there's also something called the joint capsules. These are ligaments that surround that ball socket joint like a bag. And the nice thing about it, typically they're nice and loose until we get our shoulder all in places. If that scars down and gets tight, you might not have that motion. It becomes called a frozen shoulder. If that stretches out or worse is torn, then you might have a loose shoulder that dislocates with certain activities. So that capsule is a very important part of our shoulder structure anatomy as well. Then we discussed this arch overlying that rotator cuff. And what that is bony anatomy, the clavicle, the collarbone itself, the acromion, which is that roof on top of the shoulder, and ligaments that combine them. Okay? And the important piece of these anatomical structures is they form a rigid bony structure above those soft tissues. So we basically have the bone of the ball of the shoulder. We've got the rotator cuff, which is soft tissue tendon, what's called the bursa above it that we'll get into, and then that bone and ligament is solid anatomy above. So for different reasons, we might pinch those soft tissues between the bones and basically get and then we get what's called impingement, impinging those soft tissues between those bony structures. There's lots of bursas in the body. What these are lubricated sacs of soft tissue that are in different joints to allow lubrication, fluidity, and nutrition, and prevent friction between these surfaces. And the unfortunate thing is these can get inflamed and irritated and cause symptoms in the shoulder as well. So how do these things happen? What is the typical mechanism of injury when we're dealing about shoulder pathology? First is a fall. And typically you can fall on the shoulder itself, or commonly you can fall on outstretched arm. And what happens, the forces of the ground pass through your hand, through your wrist, up your forearm, across the elbow, and get into that shoulder. So you don't necessarily need to be hit with a baseball bat in the shoulder, but you can actually land on a hand and develop shoulder symptoms. Also, repetitive activities can cause these symptoms. So if someone's a pitcher, repetitive throwing, people are hanging things on shelves or putting them on high shelves all day long. Repetitive cleaning, waxing, overhead sports can all cause these symptoms to come about. And again, an indirect injury like falling on a hand, or a direct injury where that shoulder is struck either by the ground or a solid object that's falling, can all cause shoulder symptoms. So then we talk about the difference between a strain and a sprain. And this is just not a huge important piece of the puzzle, but the fact of the matter is when we're talking strain, we're talking about injury to muscle or tendon. And what's happening is those fibers are getting overextended, overstretched. You can tear those partially or completely. Sprain, on the other hand, is referring to ligaments. And this could be a ligament that's just partially torn, or pissed off, or irritated, or worse, torn all the way through. And typically with all these shoulder problems, there's a spectrum of injury, because something is pissed off and irritated and inflamed. Or maybe it's overstretched or partially torn, or in the worst scenario, it's completely ripped off a bone or pulled in half. That would be a complete tear of these different structures. So I talked briefly before about impingement. This is a common term that's thrown around, and what that is, again, is these soft tissues getting pinched between the solid bone above and below. And what happens is, if it's repeatedly beat up again and again, or worse, you develop some arthritis of the joint between the collarbone and top of the shoulder blade, you get spurs that poke down, and all of a sudden that space is even less. And by diminishing that space, especially with rigid bony structures, it can irritate even more that bursa that can create inflammation, or worse, carve a hole in that tendon to create a rotator cuff tear. So you hear about a spur or hook, these are the things that we're talking about. And inflammation in the body is itis. So in this situation, you get rotator cuff tendinitis. There's inflammation of that tendon, or bursitis, inflammation of that bursa. So rotator cuff tendon problems, like all tendon strains, are a spectrum of disease. Sometimes it's irritated and pissed off. We can manage that very easily with non-operative management techniques. Or in the worst scenario, it's literally ripped off the bone. And that's what a tear is when it comes to the rotator cuff. Most times the tendon literally pulls right off the bone itself because of some traumatic event that occurs. And then we also describe them based on how many tendons are torn. We talked about there's 4 different tendons of that rotator cuff. You can have 1, 2, 3, or 4 tendons torn. It may be torn off a little bit with a small tear, or all of them may be torn off and pulled past the other side of the socket. You may have a massive tear of that rotator cuff. The problem with these tendon tears is they don't heal. Once they're torn for good. And the way I describe this to my patients, it's kind of like pulling on a rubber band. If I pull that rubber band at both ends and cut in the middle, it springs to both sides. Only way to get together is take those ends and tie them together. That muscle sitting on top of your shoulder blade is pulling towards your neck. If you pull the tendon off the bone, it's now pulled towards the neck. It can't go back and reattach unless we take it surgically and reattach it there. You can live with a rotator cuff tear. It's not a life-threatening thing, but it may be symptomatic. And depending on your activity level, how many tendons are torn, how long they've been torn, how symptomatic someone is will determine how aggressive we get with surgical versus non-surgical treatment. The important piece of the puzzle is that that muscle that's no longer connected to the bone, because the tendon's pulled off, can't get stronger. So no matter how much you work out in the gym, no matter how much physical therapy you do, you can strengthen everything else up in the shoulder, but that muscle will atrophy and wither away over time. And at some point in time, it becomes what's called an irreparable tear. You can't fix it anymore. And then you're looking at other more challenging surgeries and options to help manage those patients' symptoms, knowing full well their cuff can't be fixed anymore. So in a young, active person who has a big tear with no atrophy, that's the one you want to particularly jump on earlier than later to get it fixed before that atrophy and irreparable situation occurs. So we'll talk a little bit about a shoulder dislocation versus separation. A dislocation is where the ball actually comes off the socket. And on the left side here, you can see that ball sitting right on the socket itself. You can see what a dislocation looks like on X-ray, where the ball literally comes off the socket. And so that's typically happening with the falling outstretched upper extremity. So you're sliding to second base, falling off the ladder onto your arm. What happens is that arm gets cranked back, and that ball gets wedged and levered off the socket anteriorly. Okay? And that usually is an anterior-inferior dislocation, the most common direction that it comes out of. Versus someone who's maybe riding a bicycle in the city and jams on the brakes aggressively. With this position, the arm gets blown out the back. You get a posterior dislocation of the shoulder. So describe that dislocation based on the position of the ball in relation to that socket, usually out the front, back, or inferior. So a shoulder separation is a very different thing. This is actually a separation between the collarbone and the top of the shoulder blade itself. So you see a normal X-ray on the right once again. On the left, you see there's widening of that joint space. And this typically occurs in hockey most commonly. Guys get checked into the boards, it drives the top of their shoulder down, tearing the ligaments between those bones and separating the shoulder. Another common thing is falling off a ladder onto the top of the shoulder. If they don't react fast enough to get that arm out and dislocate it or fracture it, they land on the shoulder, and that's another way to separate your shoulder. So that's the difference between separation and dislocation of the shoulder. Shoulder arthritis. A lot of people come in wondering what this is. They worry if they've got it in one joint, it's going to spread to another place. They worry it's contagious. That's not the case. There's lots of different types of arthritis. You can have rheumatoid arthritis or inflammatory arthritis, which is a systemic problem that affects all the joints in your body. Or you might have what we're talking about here, which is osteoarthritis, more relevant to the workforce where you may have an injury. And then the question is this work-related or not, if there's an arthritic shoulder that's pre-existing. What this is wearing away of that surface cartilage. The way I describe it is kind of like a balding tiger. People are wearing away their tread. And when they're riding on the rims, now the bone is exposed. Because that surface cartilage is worn away completely, and now there's bone touching bone, and you hear about bone-on-bone arthritis. So this doesn't spread or travel, it's isolated to one joint. There may be a genetic predisposition where you might have multiple joints involved, or a lot of people in your family get it, but typically it's mechanical wear and tear on that joint where you rub away that joint surface, and then you have an uneven surface instead of smooth, shiny surface gliding past one another, the more cobblestone surface grinding past one another. And the good news is this can be asymptomatic. And many of us may have arthritis in the room of our knees or hips, and we don't know it until one day we get an X-ray and someone shows it to us. So just because you have it doesn't mean it's going to hurt. And the question becomes what's work-related and not in a work comp setting. Then there's the other type of cartilage that we refer to, this ring of cartilage, the labrum, that can get torn. When you hear about something called a Bankart tear or a slap tear that you hear about, these are tears of that ring off of the socket itself. And these are much more common with overhead athletics. We see them very common. But that's what we're referring to when we hear of a cartilage tear, usually it's the labrum. This is a wearing away, that's the surface of the joint, what we're talking about. So all these bones can fracture. And people always ask if it's a hairline fracture, if it's a big fracture, a small fracture. Really, we don't describe them that way. It's either broken or not. It's either open or closed, meaning it's sticking out of the skin, or it's not. And then how out of place and how many fragments are there. So those are the ways we look at it. Which bone is involved, how badly is it broken, and how many pieces is it in, how far out of place they are. And those particular factors dictate what needs to be done. Whether it's surgery or a sling, or we have to put it back in place somehow by manipulating it in the emergency room. But all these different bones can be broken in all different ways. So we move on to the history, and this is an important piece of the puzzle. I can't tell you how many patients come to my office, say they've seen a doctor or an IME physician that never spoke to them. They walked in, looked at the record, and walked out. The reality is you cannot evaluate a patient and come up with a diagnosis without taking a history. There's a lot of questions that we might be asking that may or may not be thought to be relevant. But those details, especially in the legal environment, are important because if it's not documented, it didn't happen. So you could do the most thorough physical examination, but you don't have the history to back it up, that's a problem. So it's very important, obviously, that you speak to the patient, to hear about the present symptoms, how they came about, past history, what went on before, and what treatment has been done. Because we don't need the same thing over again if it didn't work before. We need to try something different to try and make the symptoms better. Physical exam, same thing. I can't tell you how many patients I hear about that the physician never lay hands on them. You can't examine a patient unless we put hands on them. The good news about orthopedics, especially the shoulder, is I can touch these things. The cardiologist can listen to the chest, they hear the heart, they can't get their hands on it. I can actually palpate that shoulder. I can feel the clavicle from the sternum all the way to the AC joint. I can rotate that ball of the shoulder under my fingertips. There's different bumps and grooves on that ball I can feel. I can feel whether the present, where they hurt. I can palpate that biceps and the groove that it travels in. So it's very important to get our hands on those shoulders. In addition, depending on the position their arm is in, may indicate which symptom, which structure is involved. Very important to know the mechanism of how these things came out and to be able to put things back into place, typically reverse the pattern of injury to get them where they need to be. Another piece of the puzzle that's important on examining these patients is evaluating their neurologic and vascular status. Because we do surgery. What do we do in surgery? We're in your nerves, we're in your blood vessels. Those can get cut. Now, if we haven't examined the patient ahead of time, how do we know if they were cut by the injury or that fracture of that ragged bone, cutting the nerve, or I cut it with my scalpel? Very important to document this before the surgery, whether it's intact or not. In addition, important not to torture this patient. I mean, it's always entertaining to me. My patients come in and I'm examining the other shoulder first to see what normal looks like. Nice thing is I get to look at both sides to see what their normal is compared to the other side, because all our shoulders may examine very differently. They look at me funny because they think I don't know what I'm doing because I'm examining the wrong shoulder. One doesn't hurt. But I was trying to go the most painful thing last because I know it's going to hurt. It's like little kids come in the office. I evaluated their elbow to see if there's an elbow problem when they come with a wrist fracture. I'll look at the x-ray first. There's no reason to touch their wrist. They're 6 years old. I walk in with a white coat. They're freaking out to begin with and crying. You don't want to hurt them. I don't need to push on what hurts. Same thing with the shoulder. If I know something definitely is going to hurt, no reason to go there. I'll work around it, make sure there's not any other associated symptoms or pathology. No reason to torture our patients in the office. Then we move on to imaging. And these are also an important piece of the puzzle, but don't answer everything. I'll typically look at an x-ray ahead of time if I can, to again try to avoid hurting someone or moving something out of place that's in place. But x-rays are key. And the x-ray is really just a shadow, that's all it is. We take a plate, we put it behind their body in film, we shoot an x-ray beam through their body. If it hits metal, it shows up white on most x-rays. If it hits air, it's black. So it's really just a measure of density. So the whiter something is, the more dense it is. And so it allows us to evaluate the anatomy in 3 dimensions, but this is typically, again, a shadow, so it's a 2-dimensional picture of a 3-dimensional object. So you need to rotate the body in relation to that plate and beam to really see that anatomy in 3 dimensions of a 2-dimensional picture. So one x-ray is never good enough, and in the shoulder typically you need a minimum of 3 to evaluate it appropriately. Ultrasound is another thing that's famous for looking at hearts and pregnant bellies, but we actually look at it and usually look at things in the shoulder as well. We can evaluate rotator cuff pathology and tears with ultrasound evaluation. We can follow progress of healing of our repairs many times with an ultrasound. The reality is that it became very much more in vogue in the past 5-10 years. A lot of orthopedic surgeons were not trained on it, so don't know how to really look at it very well or do it on their own. They need a technician to do it. It's very technician dependent, but it's definitely a way to look at anatomy in the shoulder. An MRI is thought to be the holy grail by a lot of people, a lot of patients, a lot of primary care physicians. I can't tell you how many people walk into my office with an unnecessary MRI. It's frustrating because many times it's the first imaging technique utilized. It's also one of the most expensive. And so we can avoid that many times by getting the appropriate views of using appropriate x-rays. And so I would always suggest not to jump to the MRI because it might be found to be unnecessary. Also, not all MRIs are created equal. Just like a Polaroid picture is very different than a high-def camera, the fact is open MRIs are not as good as closed MRIs when it comes to the quality of the magnet. So you want to make sure if you're going to get an MRI, that you get the right one, not just any MRI. And unfortunately, a lot of the contracts that these employers have are with cheap MRIs. And so they come in, and the patients and the case managers are wondering why I want to order a better one. So quality is key. There's some structures in the shoulder, like that labrum, that are very small. or you may have a very small, subtle tear, and an MRI, even a good quality one, might not be good enough. So before you have that drop kick response to go get that MRI, you want to make sure that you don't need an MRI arthrogram. What this is where we inject radiographic dye into the joint. That joint fills up spaces. There are some spaces that are normal, some that are abnormal. So now you can find some very subtle pathology that you might miss on a regular MRI. So again, don't just get a test because it sounds sexy, but a test that is the right one for the right reason at the right time. A CT scan is a fancy kind of an X-ray. You can't look at our bones in 3 dimensions. It's much more radiation than a regular plain X-ray. This is really used for looking at bone in greater detail, where the MRI is better for looking at soft tissue. So again, you want the appropriate study for the appropriate problem at the appropriate time. Talk a little bit about the open versus closed. One of the challenges with these closed MRIs is a lot of people are very claustrophobic. And if you've never been in a closed MRI and you're a big person or have wide shoulders and you go in there head first, it's like you're in a coffin. You can't raise your arms and move. And it can be pretty scary. And so sometimes we've got to get an open MRI for people that are claustrophobic, or maybe even sedate them in the hospital to get the imaging done. But even if they come with an MRI, most times I'm going to ask for that X-ray when I see them in the office, because those things are still seen better on X-ray than MRI, and it may be a valuable evaluation. How do we treat these people? Typically we shut them down. Something hurts, don't use it. And the way we do that at the shoulders, there's really no cast to put on a shoulder. You have to go around someone's neck. So to immobilize a shoulder, even in a fracture setting, we put them in a sling. And usually just kind of taking gravity out of the picture creates a significant amount of pain relief for them. Modalities are other things that we utilize. People always ask me, should I use heat, should I use ice? And my answer is, try both, see what feels better. But typically, we cool down, we warm up before, cool down after. So if we're going to physical therapy, or we're going to go work out, a hot shower, moist heat, steam room to kind of loosen up the soft tissues. And after, if you're sore, or you're in pain, had surgery, put ice on it, decrease swelling and inflammation. So warm up before, cool down after is typically the teaching. All different types of devices you can use. Just routine ice packs. Get a Ziploc bag, throw some ice in it, does the job. Sometimes you try and get fancy. There's a lot of devices out there. They're mostly a lot more costly. Some of them have compression. Some of them circulate the water with a cooler. They all are pretty much doing the same thing, depending on the insurance plan and the desires of the patient. You may use one over another, but they all work very well. All different types of pain pills that we utilize. We try and not use a lot of pain pills in my practice, typically. The ones in the orthopedics office are typically anti-inflammatories and narcotics. Narcotics are obviously a big problem in our country. We're typically using them in 2 circumstances, only in my office, which is in a fracture setting, early on, or post-operatively. For arthritis, I will not use it. For tendonitis, I will not use it. Anti-inflammatories, we've got to be careful, because now we know with cardiac disease it might cause some issues. If someone has any GI issues, ulcers, gastritis, not an ideal thing to use. So I happen to use injections a lot more judiciously than I do a lot of these medications, because I think these are systemic medications, can cause a lot of other side effects, interactions with other drugs, so we can avoid them. Ideally, that's the best. But cortisone is something people freak out about. I can't tell you how challenging it is in my office. The most challenging part of giving cortisone injection is convincing people it's not going to be a big deal. They come in with an amazing amount of stories and myths that they hear about that are bad for you. You can only get a certain number in a lifetime. People think it makes them fat. They think they destroy your bones, and they're horribly painful. These really are not true. The fact is they help. I'm injecting people all day long, couldn't do it if it wasn't working. The meds are not so systemic. They work and act locally, so really get the most bang for your buck, putting the meds right where it needs to be, as opposed to dissolving in your stomach and going to the entire body. How many you get depends on where you're injecting and why. There's certain parts of the body, like the Achilles tendon. The number of injections I will give someone in their lifetime near their Achilles, 0. It's been shown with 1 injection, you can rupture that tendon completely. So again, it depends on where you're injecting and why. There's about 5 places to inject the shoulder, depending on where I'm injecting, what the reason is for, how well it's working, determines how many and how often I can do it. And the fact of the matter is that medicine doesn't hurt. The lidocaine, which is a numbing agent, may burn a little bit, but it's the needle that hurts, and it's really not much worse than getting your blood drawn. So if you're freaking out getting your blood drawn, you might freak out about getting the cortisone injection. But the reality is, that's really all it hurts is the needle itself, and it's not that big of a deal for most people. And these things don't destroy stuff. They decrease inflammation. Too many, too close together, the wrong location, that would be a problem. So. Complications are really few and far between. Knock on wood, I've never had an infection after a joint injection. I've never injected a nerve and caused damage in it. But the biggest thing is weakening of tendon or rupture. So if you do too many near that rotator cuff, too close together, that can compromise either healing after surgery or can cause that tendon to tear. So that's why you want to spread them out and not overload that joint. Some people get this whitening of the skin if you do it very superficial near the skin. When we're injecting the shoulder, it's deep underneath the deltoid, so most times you don't get that whitening. People with diabetes, it bumps their sugar for a few days, but really there's no major complications I've seen, and that's a good thing. Physical therapy, another thing a lot of patients are hesitant to do. They don't believe in it. Now, while it's not a religion, the fact of the matter is it helps, and our bodies are machines. So you take your car for a tune-up. Physical therapy helps tune up your body. Most of us, no matter how much we work out, aren't always doing it the right way. And they can really focus and hone in on your imbalances, things you're doing incorrectly, give you some good exercises so you're doing things in a proper way in the gym or at your home to help get this joint back where it needs to be, whether it's to avoid surgical treatment or to rehab after an operation. And again, it shouldn't be painful. In the beginning, after an injury, whether it's a fracture or surgery, we don't want to torture these patients. We're trying to decrease pain and improve motion. We're not throwing a 10-pound weight in their hand day one after an operation. So if they're doing the wrong thing, maybe it's the wrong therapist. It should be a gradual progression. They may need to be pre-medicated with an anti-inflammatory or some pain medicine early on after surgery before they go, but should not be a miserable experience and should be progressively improving. You know, if we're getting notes from the physical therapist that nothing's different, it's the same carbon copy every time, well, it's time to change gears and do something different, whether it's surgery, injections, or something else to get these people back where they need to be. Something as simple as activity modification. Many times we're working overhead. Get a little step stool, so you're working below the shoulder level. I tell patients all the time, don't reach that grocery bag out of your back seat and lift from behind your body. Not a good place for your shoulder to be. Open the door from the back seat, pull out in front of you. Keep things below the shoulder level. Just adjusting activities, whether at home or the workplace, when you're recuperating or trying to help decrease symptoms, are really a very simple thing to do and something that people just don't think about often because we're in a hurry. So when do we operate? You know, number one, patient compliance is key. If I know someone's not going to behave after an operation, they don't listen before surgery, that they have a substance abuse issue, someone that has not much help at home, these are people that might not be the best people to take care of surgically because if they can't do what it takes to manage the shoulder after an operation, it can be worse. Because now you've got scars and anchors and stitches and all types of things that they can pull apart. Now you've got a bigger problem with the shoulder than they had before. So you want to make sure they're compliant, number one. Number two, that they've complied with non-surgical treatment to get better and failed that. So it's not typically the first answer unless you've got a fracture of the bone sticking out of the skin. That's right to the OR. But most things we can make better non-operatively. But again, if they have failed non-operative management, then it's time to move forward with surgical resolution of their symptoms. And what are we trying to do? First and foremost, get rid of the pain. With a joint, the most important thing is maintain their motion. Because if we fix something but they can't move their shoulder again, that's not a good thing either. We want to manage all the pathology, not just one. Many times there's multiple things that are causing symptoms. You want to address every one of them, not leave one behind. That's the culprit of persistent complaints of pain. We want to make sure whatever we're doing is strong, because people do misbehave or have accidents after surgery. So you want to make sure that our repairs are super strong and solid to withstand some poor behavior. Ideally, if we do most of these things as outpatient, that's great. Even our joint replacement partners are doing knee and hip replacements in outpatient surgery centers these days. Huge advantage financially and socially and emotionally for these patients. And we want to give reproducible results time and time again to get these people back to the things they're dying to do. So what do we do surgically? You hear about this word decompression. What we're doing in the shoulder, we're taking those inflamed structures and we're getting rid of them. So we're cleaning out that bursa. Maybe those spurs that are poking down on a rotator cuff, we can shave those away to smooth them out and open up that space. We're not having that impingement experience to our soft tissues. So that's what a decompression is. You're decompressing that space that is tight and opening it up and getting rid of the inflamed tissues. In a labral repair, we're literally repairing that washer or that lip on the golf tee back down to the bone. Again, done with stitches and anchors to get that thing to heal and get them back to doing all the things they want to do in life less symptomatically. The biceps tendon, as I talked about before, if you look at that picture in the upper right-hand corner there, you can see there's those green sutures around the base of the biceps tendon. We're right at the top of the labrum. When you hear about slack tear, S is superior, L is labrum, anterior, posterior. So your superior labrum is torn off typically with the biceps. So that's where our biceps attach to the inside of our shoulder. There may be different reasons within the shoulder that you need to do work on that bicep, not just the labrum that surrounds it. And the two things we typically do are either cut it, and that's called a bicep tenotomy, or anchor it in a different location. What we learned over time is that some people have partial tearing of their biceps tendon. And they're lifting something, all of a sudden they feel a pop. They get this Popeye deformity. You can see in that picture on the top left there, where the muscle kind of bulges down a little bit. Instead of a long muscle, it's kind of curled up. And all of a sudden their pain's gone. So we learned from these people historically that sometimes when you tear your biceps tendon completely, your pain goes away. And so we've learned surgically, sometimes in certain people, that's the right thing to do. We literally cut the biceps. They live with that cosmetic deformity, and most people don't really have much functional deficit. In fact, I was on vacation with my dad recently after he tore it. Looking like I was crazy. I had him flex me, saw it, and I was consumed with the fact that he tore his biceps when he didn't even know I had it done. So the reality is people do very well with a long bicep tendon tear. But certain individuals, like manual laborers, people who do repetitive activities over and over again, like with a screwdriver, people that are bodybuilders that really are concerned about that symmetry. We do what's called a tenodesis, which is we cut that biceps and then anchor it in a different location, not onto the socket, but onto the ball itself. And this is decreased earlier fatigue and allows a little bit more endurance in those repetitive activities, and also maintains the cosmesis of the upper arm. So that's what a tenodesis versus a bicep tenotomy is. What do we do in a rotator cuff situation? It's torn off the bone, we anchor it back onto the bone, much like that labrum. We're using sutures, we're using anchors, we use metal anchors, we use plastic anchors. Sometimes we use anchors that dissolve and disappear and turn into bone over time. And there's all different preferences and reasons why you might choose one over the other. For arthritis, we can't get that cartilage to heal. Once it's gone, it's gone. That's why my partners that do joint replacement surgery are very busy. I actually do shoulder replacements. I no longer do hip and knee replacements. But what we're literally doing, because we can't get that cartilage to heal, we need to replace it. And there's no good way to replace it with cartilage. We replace it with a metal and plastic joint. So here, you're seeing cartoons, you're seeing photographs, and then an x-ray of this metal stem that goes down the top of the arm bone, a metal ball that goes on the top of that stem, and then you can't see it, but we cement a plastic cup into the socket. And so that's what a shoulder replacement is, a plastic socket, and typically a metal ball is how we replace the shoulder. The reality is that for that to work, you need a rotator cuff. The rotator cuff has to function for that particular thing to do well. If you don't have a rotator cuff, you can't do that operation. It will fail every time. So in the setting where someone has an arthritic shoulder and a rotator cuff that's torn and cannot be fixed, then we do what's called a reverse shoulder replacement. I won't get into technical details, but the long and short is we now screw a metal ball onto the socket, we put a metal stem down the center of that top of the arm bone, and we put a plastic cup on the top of that stem. And so it's called a reverse because we actually put the ball on the cup side and the cup on the ball side. And then this is a unique circumstance that we're doing in certain settings that are non-amenable to the regular shoulder replacement because primarily the rotator cuff is not something that is able to be fixed in certain people. And all these fractures need fixing. Not all of them, but many of them. And we can use rods, we can use plates and screws, use pins, all different things. So depending again on what bone, how out of place, how many pieces, determines what's used for each one of these structures. How do we get the job done? We can do it through an open operation, or we do it through what's called a mini open incision. So in an open operation, many times, we need to do it because you're putting a big shoulder replacement in. I can't put that shoulder replacement in through poke holes. I got to get the job done through a big open incision. There's certain surgeries where we can go between the deltoid and the pec. There's other ones where we have to take the deltoid off the bone. Okay? And now we take the deltoid off the bone, we got to repair that to the bone. If people misbehave, you can tear that off. Now you got a bigger problem on your hands. So depending on your surgical skill set, when you were trained, how you were trained, what kind of operation you're doing, you might do it through a big open incision, you might do it through smaller incisions, or you might do it through arthroscopy, which is what I do a lot of, which is little poke holes. So what we'll do is make poke holes around the shoulder. In this rotator cuff setting, typically 4. Each poke hole takes 2-3 stitches to close, and one I put a camera on, and the other one I use my instruments. And now I'm looking on a TV screen with fiber optics, so I'm not even really looking at the shoulder, I'm looking at the screen and getting the job done. So it's really good for your video game skills if you're into that kind of thing. But that's what I do a lot of my work through. So what are the variables? Well, obviously, we're trying to get these people back. And there's some things that are pretty consistent in my practice, some things that are not always consistent and somewhat out of my control. The first is the type of sport or activity they're involved in. If they have a sedentary job, they're sitting at a desk typing, I can get them back pretty quick. Now, they may be in a brace, they may be on pain medication, they may be tough to get to and from driving. The long and short is there's accommodations that can be made in certain settings. We'll try and get them back before they're done recuperating. Because many of these things can take 4 to 6 months to resolve. If someone's a physical laborer, a firefighter, a police officer doing overhead work, it may be at least those full 6 months to get them back without restrictions, despite feeling pretty good before then, because things are just not ready for that type of force to go across them without re-tearing again. So that's some of the variables. Now there's pain control. Everyone's different. I can't tell you. I got some people that come in not even taking the narcotics after surgery. Other people, we have trouble getting them off them because they really are liking those things, so their pain tolerance is pretty poor. The commute is, again, another important thing. I had a patient just the other day in the office fighting with his wife. Doctor, tell her I can drive. Well, he's got a brace on, he's not on narcotics, and I'm not getting into that. That's a dispute. The long and short is they've got to be safe. And once they feel safe, they go ahead and drive. Also, what arm is involved? Is it left or right? The right hand dominant plays a role. The surgeon's skill set, skill level, patient tolerance, compliance, their motivation. You know, if someone is an athletic, motivated individual, they have a physical job, they're a firefighter, police officer, they might want to get back to work and do so easier versus someone that really doesn't work it out at all, is not physically active. And you know, all of a sudden, physical therapy is the first activity they ever had in their life in decades. That's going to be a more challenging circumstance to manage. The biology that we're dealing with is a key. I mean, if you've got a fracture in 2 pieces versus 15, that's a different thing to manage. If one rotator cuff tendon has a small tear in it versus all 4, very different thing to manage. So what they're presenting to me are variables that I've got to manage and work with. So what are the constants? Typically, if you've got a surgical condition or a fracture, you're going to be off 1 to 2 weeks minimum, mostly due to the pain control and just being able to get out of the house and not being miserable. Many times after surgery or a fracture, we're using a brace up to 6 weeks, whether it's this kind of brace that I use for my rotator cuff repairs or a sling or something that straps you to your belly, depends on the type of surgery or problem that they have. Physical therapy begins anywhere from 3 to 6 weeks after the surgery, usually lasts 2 to 3 months. Unless they're in a physical occupation, it might take longer, it might need the addition of work conditioning to get them back where they need to be. But most of these problems, MMI is typically 6 to 9 months, plus or minus work conditioning FCE at the end, depending on what their activity level requirements are at work. And I don't send everyone for these things, it really depends on where they are. If they're feeling great and have a physical job at 6 months, let them go back without these evaluations. But if they're struggling, or we really are not sure they're going to get back without restrictions, that's where these things come into play. So how do we prevent these things from happening, all of us in the room here? Number 1, maintain your flexibility. That's key. The fact is, most things we get in orthopedics as we get older are due to the fact we're not flexible. We're stiff, and then we overstretch things. I tore both my hamstrings a couple of years ago because I was chasing kids down the street that were throwing snowballs in my car. It was a brilliant idea. But the long and short is, my hamstrings are not flexible, and boom, popped. My kids were laughing. It was not this cool. The other thing we want to do is strengthen, and strengthen properly in a controlled setting. How are we going to do that? We want to make sure we have the right form. You know, people come in all macho, they're lifting those dumbbells in the gym, and they're doing this. Well, all they're doing is straightening their back and legs. To straighten your biceps, you got to straighten the elbow all the way and bend the elbow all the way. So doing it with the right form is really key. So that's where physical therapists and athletic trainers can really come in. Typically, we don't need to be macho at this age. We can go ahead and use low weights, high reps, much more valuable than trying to max out on your bench press at our age. I'm talking about the men here, okay? Maintain your cardiovascular fitness, maintain your core strength, really key. You're not just lifting with your arm, you're lifting with your whole body, your abdomen, your back, your legs. So important to maintain the strength of all these different things. Also, we want to lift close to the body. So if we're lifting, keep it close to the body, not overhead, not away from the body. If you hold a 5-pound weight in your hand, it's much heavier if you hold it out here than holding it closer to your body. So these are things to be aware of and cognizant of as ourselves or our patients. You don't want to work through painful things. I mean, most people come into my office that are athletic or laborers, they're sore all the time. But they're coming in because there's a different pain that's come about. And so you want to treat that differently, not fight through it, is what I tell a lot of the athletes I take care of. So lots and lots of things can cause shoulder pain. I just scratched the surface with some of these. The good news is most of them don't require surgery to get made better. And so we can manage most of these people, even with tears non-operatively in my practice. That's an important thing to know. So I don't know if I'm over or behind, but if you guys have any questions at all, I can take them now. Yep. So the question was talking a little bit about shoulder replacement surgery, how effective it is, if there's restrictions that may be permanent afterward, and how long it should last. The first thing I would say is it depends on if we're talking about a reverse shoulder replacement or the anatomic where the ball belongs and the socket where the socket belongs. So let's talk about that because that is the most successful one and the ones that get you closest to normal. Okay? And what I mean by that is typically the rotator cuff is intact, and that's an important piece of the puzzle. The recovery from a shoulder replacement, different than a knee or hip, is that we have to cut through the rotator cuff to get inside. So you're basically creating a full thickness tear of the front part of your rotator cuff. On the way out of the shoulder, you repair that. That has to be protected in a very different way than doing a knee or hip replacement. Hip replacement, you really don't cut through many things. You kind of divide the muscles and separate them, and you can basically walk, and there's not a whole lot of therapy that needs to be done besides walking in a hip replacement setting. Knee, different, need a lot of rehab for that. But a shoulder, we've really got to protect that rotator cuff because if you misbehave and tear it, that's as bad as trying to do a shoulder replacement in someone that doesn't have a rotator cuff to begin with. So that's where the protection comes in that's different and more challenging after a shoulder replacement surgery. But the results are great. And the fact of the matter is, ultimately when we're done, your goal is a full range of motion and no pain. In terms of pain control, that's why we do it. More than function, we're trying to get rid of someone's pain. So if their main complaint is function, that might not be made completely better with a shoulder replacement. If their main complaint is pain, that's typically a home run in most cases. Okay? In terms of their function, most shoulders that are arthritic are stiff. So if the complaint is, I can't get my arm all the way up to reach my top shelf, I can tell you with a shoulder replacement, I'm going to make that better, for sure. Am I going to get the range that you have on the other side? I can't promise you that. That's my goal and probably can be accomplished, but not as reliably as pain relief. Okay? In terms of how long these things last, we used to say back in the day, especially the knee or hip, 10, 15 years. Well, the fact of the matter is, if it is done well by the right surgeon with good technique, all the equipment that we put in is pretty much the same and not that different these days and all does great. The goal is to have it last the rest of your life. Whether it's a knee replacement, shoulder replacement, why does that not happen? Was it done well, potentially? Maybe you were beaten up on it. I mean, these joint replacements weren't made to go lift and bench press with. Okay? The knees weren't made to run marathons on. Given that, I was skiing years back, and I was chairman with a guy that was talking about he had both knees replaced. I said, "Does your surgeon know you're doing this?" I said, "This is why I had it done, so I can see." So I always tell patients that my goal is to get you back to doing everything. Those things probably are not going to last as long if you're doing them. So if you're pitching with a shoulder replacement, you're probably going to wear out that plastic. The metal's not going anywhere. The plastic will wear out over time if you beat up on it too much. But the goal is ultimately to last the rest of your life. The fact of the matter is we try and be judicious about the age we're putting these in. Stu and I, me was reading it over here a minute ago, there's a guy that he's got shoulder arthritis in his 30s. The fact of the matter is that shoulder replacement is probably not going to last till he's 80 because it's just going to wear out over time. Versus someone who's in their 60s, that shoulder replacement is probably going to last the rest of their life because they're not going to wear out that plastic. So I don't know if I got to every part of your question, but hopefully I did. Any other questions at all? Yep.
Could you say again why you would order a CT scan as opposed to or in addition to an MRI or an MRI arthrogram in the shoulder?
So, in the shoulder setting, typically what we're looking for with a CT scan is the bone. I'm sorry, he was asking about the reasons behind why we order a CT scan versus an MRI or MR arthrogram. The CT is really best for looking at bone. Okay? So if there's a bony problem, that's where an X-ray or CT comes in. The CT advantage versus an X-ray is it gives us much better three-dimensional anatomy to look at. We can rotate these images, there's slices that we can look at and scroll through. And so when I would order a CT in the shoulder setting is for a very complicated fracture. So a fracture that's in lots and lots of pieces, I want to see each piece in 3 dimensions so I know where the screws go, where the pieces go, where those puzzle pieces go. Okay? The other time I order a CT scan in the shoulder setting is if I'm looking at bone loss. So sometimes when someone dislocates their shoulder, they not only stretch out that capsule we spoke about or tear that lip of cartilage, the labrum, but they might bang against the bone and knock off a piece of the bone. And that may determine whether or not I do a soft tissue surgery through a scope or a big open surgery with screws and bone work and all that kind of thing. So I'm looking at the anatomy of the bone. Now, with shoulder replacement surgery, we do a lot of patient-specific instrumentation, meaning not every patient's shoulder is the same. So we can use devices that lock onto their socket to direct how we're doing the operation to make sure that we're using exactly the right pieces for their particular anatomy. So that's where the CAT scan comes in. So we're looking at bone structure versus an MRI, we're looking at soft tissues. We're looking at tendons, we're looking at ligaments. We're adding the dye with the MRI arthrogram because it's a very small, subtle thing. Or a revision setting. So we're doing second time around surgery because someone might have a re-tear and there's an operation that's been done already. That anatomy is not going to look normal in an MRI. There's going to be all types of things. There's scar tissue, there's anchors or stitches, so things are harder to look at. And by adding the dye, may allow things to be seen better. So that's where the dye would come in the MRI setting. Go ahead.
If you have a patient that presents clinically and they have positive findings on provocative exam, and yet the MRI seems to be pretty clear, but the patient continues to be symptomatic, how do you decide what to do next?
Can you repeat that one more time?
Sure. You have a patient that presents clinically and they have positive findings on provocative exam of the shoulder, and they continue to be symptomatic, and yet you get an MRI image, and you look at the image, you don't really see any abnormalities or any anatomical conditions that are amenable to surgical intervention, but yet what do you do next?
Okay. So his question was, you've got someone that has a good, very good subjective complaints and history. They've got good physical exam findings for pathology. You get an imaging study that shows nothing. Okay. Great question. The reality is, again, the MRI is not the holy grail. The quality MRI may not be the best. Okay. Or it may be something that doesn't show up well in an MRI in general. So the biceps is a good indicator of that. So biceps pathology, even partial tearing, is not that well seen. Articular cartilage, surface cartilage, we're getting better and better with our MRI imaging, but surface cartilage in any joint not seen best on MRI. So if it smells like a tear, it acts like a tear, it examines like a tear, there may be a very subtle thing there. But in that situation, for sure, I'm going to extend my non-operative care a lot longer. Okay, because if I think there's a pathology that should show up in an MRI, and it's not there, then I'm going to go ahead and drag my feet and do a lot of other things to make them better, whether it's changing medications, injecting in one of the other 4 places, because again, 5 places to inject the shoulder. I'll use an injection to make them feel better, but also for diagnostic purposes. If one injection doesn't help at all, even for a minute, and no one's immune to lidocaine and should numb them up in that location, I'll maybe the next visit inject in a different location. And now, wow, I've got 100% pain relief. It lasted for a week, but that tells me information. So I'm going to use injection to gather more data and information to help me make that diagnosis. But I would tell you, in my practice, the number of, quote, diagnostic surgeries I do, where I just look inside one every other year, maybe, because I want to know this is the problem, this is what it needs, this is how I'm going to fix it, I'm going to get it done. So just to look inside, I hope I find something and go fishing, not something I would do, because they usually don't get better. The good news is, the rare individual in my practice every other year or so that needs that diagnostic procedure because they've got a good complaint, good exam, good history, MRI not so convincing, I drag my feet not better, I've got some diagnostic injections that pinpoint where the action might be despite not showing up on the MRI. The good news for me is that I've never not found something. So I do it infrequently enough that it's not a part of my practice for good, which is good. But the good news is every time I go in, I find something, and almost always it makes them better. Yep, all the way in the back.
What about the flip side of that question, and that is treating the MRI and not the history?
I won't even let you finish the question. He asked, what about the opposite, where someone's got something on the MRI, and it's not a good history exam for it? It's actually a great question. Because this is a big debate in the orthopedic world, and I'm very much on the conservative side of things. All right, there's other guys in our city who are great surgeons, great reputation, definitely not doing the wrong thing, but they are operating on asymptomatic joints. Okay, so the reality is, I can have a rotator cuff tear in my left shoulder right now. I mean, my shoulder hurts, but let's say it didn't hurt. I may have a rotator cuff tear. I'm going to be 49 this year, and statistically speaking, there's a good chance that one of my shoulders has one already. Okay, that's just the way life is. Our skin gets wrinkly, our hair gets gray, our tendons can tear in our shoulder. If I'm not hurting, why am I going to address and do anything about it? Okay, the challenge is that if I've got a young person, I'm young at my age, and I've got a tear there, I know it's not healing, ever. And so it may become atrophic over time, and now become irreparable where it can't be fixed anymore. And that's why I can't be so critical of my friends in Chicagoland that are fixing asymptomatic tears to prevent the risk of atrophy and becoming irreparable in their 60s. Because now you got to do a reverse shoulder in a 60-year-old, that might not last their lifetime. And then you got a huge problem on your hands if it doesn't. Versus if they're aiming to do a reverse shoulder replacement, they're probably going to die before they need a revision. Okay? That's just really the reality of it. So it's not incorrect to operate on something torn where there's a consequence that you don't get to it and now it's not fixable anymore. But my practice is, they ain't broke, don't fix it. Meaning that I can make them worse. Knock on wood, I've never had an infection after a rotator cuff repair. But if you're the first one I infect, and I did everything I can to prevent it, you don't give a damn that I never had an infection before. Your life has changed forever for the worse. So I would rather not risk the rare complications in someone that's not symptomatic, because I promise you, I could make them hurt. So, that's just my approach, but there's certain things where most orthopedic surgeons argue that it makes no sense to operate on them. A rotator cuff tear can be debated. But again, I would never operate on someone, no matter how big the tear was, that's asymptomatic. And the reason why is I can show you hundreds and hundreds of patients that I take care of that are in their 70s that have some soreness to their shoulder, that for different reasons we end up getting an MRI. They've got a 4-tendon tear, complete atrophy. They have minimal pain. They have a full range of motion, great strength. I inject the shoulder, rehab them, they go on their way, and they'll do rotator cuff tear. So again, the quantity of the problem doesn't dictate how someone feels, which is again what makes me super conservative, because I've got so many patients with bad pathology that I can make better non-operatively. Part of the problem for me is that my partners are doing chip-shot surgeries on these little tears. I'm getting the monster ones where the reps are scratching the head if I'm going to be able to fix it or not, because they're huge and crazy ugly. And so I'm making my work a little bit harder, but I think I'm doing the right thing for the patient, I think. So that's my long-winded answer to your question. Yep. So the question was, how problematic or compromising are the MRIs that some of these companies are getting, the work comp companies, insurance companies, where they're sending the patient? It all depends on the quality. I mean, for example, I used to work at DuPage Medical Group when I started my practice. We had two 1.5 closed magnets. The quality of the MRI is measured in Tesla. And typically, a great closed MRI is 1.5 Tesla. Most open MRIs are 0.3 Tesla, and really not good. Pictures are grainy, you can't see things. If someone's obese, it makes it even harder to see things. And so I went from these 1.5, two of them in our office, great images, to the Mecca IBJI. I start sending down my MRIs to my partner's magnet they've had for years, and I get the images back. I'm like, what the heck is this? They had a 0.3 closed magnet. And genius, they rented space in our building to someone with a 3.0 closed magnet. So guess where I set my MRIs? Our competitor. That some genius put in our building before I got there. Okay? And so that's how important it is to me to get the right thing, despite the fact it's not good for my business. Luckily, over time now, not only have we put in almost all 1.5 closed magnets in IBJI and don't really have any phased out all the 0.3 Tesla, but our Bannockburn office has a 1.2 open. So if someone really has a problem and needs that open MRI, I'm pushing them to go to Bannockburn, because I'd rather do that than sedate them under anesthesia and do it in the hospital. So the quality is key, and I'm not sure, because I don't know what the cost difference is, but I'm sure they can get a good deal and a good magnet. I'm not sure why that doesn't happen. Maybe they just don't know better. All the way in the back there?
Does an acute tear look different on imaging than a chronic tear?
Good question. Yes. Not always. Depends. You know. Yes. But the long and short is, we can tell if there's atrophy. Okay? Because what happens over time, fat lights off a certain way. So fat on certain images is white, or muscle is dark. And vice versa on different images. And so we're basically looking at how much of where the muscle belly is looks like fat. Okay? So if someone has an acute tear, usually there's not been enough time for that fat to develop. But not everyone develops that atrophy at the same rate. And also, if you've got part of the tendon completely torn, that will limit the amount of atrophy that develops. So for example, I could tear my supraspinatus completely off the bone, and have a full thickness tear, or I might pull the front half of it off the bone, where the back half is still attached, and so the atrophy is not going to develop so rapidly, or maybe not at all, because I can still strengthen that muscle through that muscle tendon unit that's still attached to the bone. So you might have a chronic tear that looks like an acute tear because there's some of those fibers still attached. So we're much better at seeing that there's fat there and say, okay, that's been there a while, this acute event probably didn't cause that completely. It may have worsened it or made the tear bigger or more symptomatic. So we can see that atrophy present or not on the MRI, but it always doesn't tell us definitively if it's been there for a long time or not if there isn't. Any other questions at all? So you knew it all, I did that good of a job?